Welcome, everyone, to today's session of the International Childbirth Initiative webinar series. Today, we will be discussing issues relating to Step 9, reviewing new World Health Organization recommendations for postpartum hemorrhage, and doing a brief introduction to the non-pneumatic anti-shock garment. My name is Michelle Skaer Therrien. Most of you know me as the Executive Director for the International Childbirth Initiative. I am today wearing my hat as Project Director of the Safe Motherhood Program of the University of California, San Francisco, working on projects for the non-pneumatic anti-shock garment, and also in my role as one of the members of the steering committee for the World Health Organization team for the development of postpartum hemorrhage bundles. I'd like to acknowledge contributors to today's session, Professor Siele Miller and Joe Paulo Souza, who developed some of the materials for the postpartum hemorrhage bundles, as well as Siele Miller's work developing and supporting the development of the non-pneumatic anti-shock garment for the UCSF Safe Motherhood Program, as well as members of the WHO PPH bundle steering and research groups. For those who are new to the International Childbirth Initiative, we provide a framework for the implementation of safe and respectful care practices and policies. Using the 12 steps for safe and respectful mother, baby, family, maternity care, ICI is implemented through individual health facilities through a process of self-evaluation, goal setting, and community participation. We also provide a global resource network that gathers together at webinars like these, striving to share our learning and improve the provision of care. It was created by the International Federation of Gynecology and Obstetrics, the International Mother-Baby Childbirth Organization, who sponsors this webinar series, the International Confederation of Midwives, the International Pediatric Association, and the White Ribbon Alliance. And we're endorsed by more than 35 partner organizations and continuing to grow. We're open to all birthing facilities who are willing to commit to delivering safe and respectful care. And you can find the application to join ICI at icichildbirth.org/application if you are a health facility. If you need resources in languages other than English, please reach out to me. Today, we're going to be going through the 2023 WHO recommendations around measurement of blood loss and use of a postpartum hemorrhage care bundle. We're also going to cover the 2017 recommendation when tranexamic acid was added for recommended management of postpartum hemorrhage. We're going to go over a brief training on the non-pneumatic anti-shock garment, and then we're going to hear from ICI partners on the use of these interventions, including how they manage postpartum hemorrhage while maintaining respectful care and allowing for many of the other aspects of the 12 steps to be implemented during an emergency. I am going to ask you to keep in mind some questions, and we're going to pause right now to see if anyone has heard of the PPH care bundle, and I'm going to put up that poll on screen. I'm going to ask you a little bit later if anyone is using devices for quantitative blood loss measurement and to know how many of you have used the NASG. So we'll get to that later on in the discussion. And if you have questions or comments, please go ahead and put them into the chat and we will get to those. We'll hopefully have a lot of time for discussion later on in this session. So please go ahead and let us know right now if you have heard of a care bundle, and we'll put up those results in a second. So at the end of December 2023, the World Health Organization released 2 new recommendations. The first one is for all women giving birth, for the routine objective measurement of postpartum blood loss, recommended to improve detection and prompt treatment of postpartum hemorrhage using a calibrated drape or a similar apparatus. The second recommendation, along with the objective assessment of blood loss, is the use of a treatment bundle with an implementation strategy. And the care bundle that has been recommended for first-line treatment of postpartum hemorrhage is uterine massage, the use of an oxytocin agent, a uterotonic, the use of tranexamic acid, if applicable, if not contraindicated, which we'll get to that in a moment, the use of intravenous fluids, examination of the genital tract, and escalation of care. So as this is a recommendation for a care bundle, we should talk about what is a care bundle. The Institute for Healthcare Improvement introduced the concept of the care bundle in 2002, and their goal at that time was to improve the quality of care by reducing the variation in the care delivered within intensive care units. IHI's initial results showed improvement in adherence to clinical guidelines with the use of a care bundle, and it is intended to improve the performance within a single facility for a specific condition. And I'm just showing here an illustration that we created with Lwala Community Alliance and the UCSF Safe Motherhood Program, showing the use of this bundle. So we're seeing uterine massage with the use of a uterotonic, IV fluids, and tranexamic acid. So this is part of a job aid reminder that is posted on the wall of clinics in Kenya that have started to implement this care bundle. And just to share those results, we can see that most of you here have heard about a care bundle. So half of you have heard about the PPH care bundle, 15% have heard about just general care bundles, and then 35% of you have not heard about care bundles before. So hopefully this is a helpful introduction today. So a care bundle involves the use of 3 to 5 evidence-informed interventions that should be delivered collectively and consistently. Every eligible patient should receive all of the elements unless something is medically contraindicated. And bundles emphasize communication at the facility as a critical component, ongoing discussion of the progress and barriers to the use of all the elements of the bundle. So essentially, when a condition is present, the full set of interventions should be implemented. The rationale behind this is the gap between knowledge and practice. Many of you know that you have often arrived to your health facility and you hear that a woman has not been given an intervention that your facility is equipped to provide. We know that the knowledge is there, but we are not consistently applying the same interventions in all scenarios. So if 10 patients are present at your facility with postpartum hemorrhage, why do some of them not receive every component of care? So the bundle was developed in order to address this challenge, which was identified as a primary barrier to quality care in the Lancet Maternal Health Series article, Beyond Too Little, Too Late, and Too Much, Too Soon, a pathway towards evidence-based respectful maternity care worldwide, where we found that in many cases, we reviewed a whole host of interventions that were recommended and a host of interventions that are not recommended, and found a wide variety in how they are applied at the facility level, despite the recommendations. The newest element that is part of the care bundle is the 2017 recommendation for the use of tranexamic acid for women with postpartum hemorrhage due to any cause, whether they have a vaginal or cesarean birth, but only if the first dose of tranexamic acid can be delivered within 3 hours after birth. That is a fixed dose of 1 gram of tranexamic acid intravenously at 1 milliliter per minute, administered over 10 minutes, as soon as possible after the bleeding begins, with a second dose of 1 gram intravenously if bleeding continues after 30 minutes after the first dose has been completed, or if bleeding restarts within 24 hours of completing the first dose, with not more than 10 milligrams per kilogram of body weight, 3 to 4 times daily, not to be given if the woman has a history of coagulopathy or active intravascular clotting or convulsions. If more than 3 hours has passed since she gave birth and the first dose of tranexamic acid had not been delivered within those first 3 hours, tranexamic acid may be harmful and she should not be given any doses. So in this case, if you were using the care bundle and you had a woman who had delivered more than 3 hours ago, the care bundle would consist, a complete care bundle would consist of uterine massage, a uterotonic, IV fluids, examination and escalation of care. And that would be a complete bundle for that patient, excluding tranexamic acid, because that would be contraindicated for a woman who had delivered more than 3 hours ago. So the other way care bundles expand upon the way we traditionally use interventions is measuring the bundle is necessary to know if you're achieving your goal. It simplifies evaluation with an all or nothing measurement. So if a single component is missed, it is counted as 0. So for example, if this woman in the illustration on the right received uterotonics and TXA and was not also getting IV fluids, she would be counted as having an incomplete bundle. She would be counted as 0 in the count of how many women received a bundle that month. The unit of measurement for a care bundle is the facility and the patient. For each patient with PPH at your facility, did she receive a complete bundle? And at the end of the month, what percentage of your patients received the complete bundle? And there should be debriefing with the care team. If not, why not? And this provides an opportunity to assess challenges and improve when you can understand which elements are not being delivered consistently. And the goal of this also is to reduce discrimination in care, as every woman who comes to the doors who has the same presentation should be receiving the same management. So when we conducted the technical consultation for the postpartum hemorrhage care bundle, which was published in 2019. If you want to read the full article, it is Postpartum Hemorrhage Care Bundles to Improve Adherence to Guidelines, a WHO technical consultation. Along with that first bundle that is now being recommended by WHO, which was adapted from our findings from that consultation, we also proposed a second bundle, which involved the use of the non-pneumatic anti-shock garment and the uterine balloon tamponade. So I'm also going to go over the use of the non-pneumatic anti-shock garment, although it was not put into the bundle recommendations at this time, but the NASG was recommended by WHO back in 2012 and continues to be recommended. So as we're getting started talking about the non-pneumatic anti-shock garment, I want to ask all of you, how many of you have access to the NASG in your facility? So that poll is up now. Please go ahead and put in your answer. I'll give you a few seconds to do that, and then we'll share the results. So we're now going to talk about the non-pneumatic anti-shock garment and its role in obstetric hemorrhage. The NASG is used to manage or prevent hypovolemic shock for women who have experienced an obstetric hemorrhage. It is a low-cost, reusable device made of neoprene and Velcro, and with proper washing and storage, it can be reused up to 140 times. It can be applied by anyone, but should only be removed by a healthcare professional in an equipped facility. So here's a couple pictures of the NASG folded up and then unfolded. You can see it has numbered segments 1, 2, 3, 4, 5, and 6, and it is applied according to those numbers, segments 1, 2, 3, 4, 5, and 6 in sequence. And the NASG has been recommended by the World Health Organization since 2012. It was included as a management tool considered during the development of the postpartum hemorrhage care bundles, although it has not yet been put into a recommendation for a bundle. The NASG has a very unique role in obstetric hemorrhage and hypovolemic shock management because it is the only device that is specifically for the management and temporary reversal of hypovolemic shock. It can be used with all the other hemorrhage therapies, including uterotonics, massage. Any vaginal procedures and surgery can be conducted with the NASG in place. So it does not compete with any other approaches. It's not an either-or situation. It does buy time to access definitive treatments. It can be used when the patient has not responded to uterotonics. And it is the only technology available that reverses shock until definitive treatment and blood transfusions are available. So I'd actually like to start with a case study from some work that was done in Tanzania. The NASG was introduced by Ifakara Health Institute and UCSF from 2014 to 2016 in 280 rural health facilities across 4 districts in Tanzania. And the majority of these facilities were dispensaries with very limited staff. Some of these were dispensaries with only a single provider available. So in this case, the woman in this picture was in labor at home, and she began to hemorrhage at home, and she bled for several hours until she lost consciousness before her family brought her to the dispensary in their region, which was at that dispensary, there was only a single nurse on call. And so that nurse, because she was alone, had to call out for someone on the cleaning staff to come and help her to apply the NASG to this woman who had already lost consciousness. So she had already been hemorrhaging at home for several hours. She had lost consciousness and needed to be resuscitated by placing the NASG on her while the nurse called up to the higher level facility to try to get an ambulance. So the mechanism of action for the NASG, when a woman is going into decompensatory shock, her heart, lungs, and brain are deprived of oxygen as the blood accumulates in the lower part of the body. The blood is also leaving the body through the vagina and pooling. So you can see how the blood is pooling in the lower part of the body, as in this illustration. And this is when the woman loses consciousness because she is not getting sufficient circulation to her vital organs. When the NASG is wrapped around the woman, wrapped around her legs and her abdomen, it is applying circumferential compression of the abdomen and legs, reducing the volume of blood in those compressed areas while expanding central circulation, reversing shock. So it is pushing the blood back up, physically back up into her heart, lungs, and brain to maintain those vital organs and stabilize her with the blood that is still in her body. And it's doing this by decreasing the radius of the blood vessels. So what happened in this case, this nurse with one of the cleaners had put the NASG on this woman. So what happened in that case, the blood was pushed back up into her vital organs, and she actually regained consciousness while she was waiting at the dispensary for an ambulance to be called to bring her to a hospital where she could receive definitive surgery and blood transfusion. So she was sitting up, she was able to drink some tea and some porridge, and she was waiting, and she had to wait for 24 hours for the ambulance to arrive. The ambulance arrived, transported her to the hospital, and she was safely treated and able to return home. So the NASG is used for any, not just for postpartum hemorrhage, but for any obstetric hemorrhage. So for placenta previa, placental abruption, ruptured uterus, uterine atony, retained placenta, lacerations, ectopic pregnancies, molar pregnancies, complications of abortion, and retained placenta. So the NASG can be applied in any of these cases if the woman is going into shock, if she is already in shock, or if she is at risk for hypovolemic shock. It stabilizes the patient and can be used while evaluating, transporting, preparing for definitive surgical treatment. And it also supports recovery post-surgery and can reduce time to discharge. It can be safely and comfortably used for up to 72 hours. It can help to avoid unnecessary emergency hysterectomy for intractable uterine atony, and it may decrease the need for or the number of blood transfusions. When the NASG has been used within tertiary hospitals only, it reduces mortality for all women with hypovolemic shock by 38%. If we're looking at just women who have gone into severe shock, this has been shown to have a reduction in mortality of 59% among women who are in severe hypovolemic shock. For these reasons, the International Childbirth Initiative has highly recommended the use of the non-pneumatic anti-shock garment to be available within birth centers and hospitals because it is highly effective at supporting all providers in the management of women who are experiencing a hemorrhage. So for a smaller midwifery center that may not be able to provide definitive treatment, it's a really handy tool to have in order to apply it to a woman before she's being transferred up to a hospital to keep her stable, to reduce her blood loss. And we're going to hear from Vicki talking today about how it's been used at the midwifery centers in the US and in the Philippines, and how it actually sometimes can reduce the woman's blood loss to the point where she does not need to be referred. And we have seen that in several countries actually at this point, that when the NASG is applied to early on during a hemorrhage, that it is possible for the woman to be managed at the lower level. That is not like the standard recommendation, but we have incidentally seen that it has been possible for facilities that don't have surgical capacity, if they apply the NASG early, to prevent the woman from losing blood and needing to be referred to a higher level of care. We also recommend it to be used at those higher levels of care because it is very effective. It can reduce costs, and it can reduce the need for other interventions. It can reduce the need for as many transfusions. So now before we go any further, I'm going to briefly show the video demonstrating how the NASG is applied to a conscious patient and to an unconscious patient, as well as to a shorter patient. So you can see that this is the medium or large. This is used in most countries. It can be adapted for shorter women. And then there is also the small NASG, which I believe Vicki is going to show you. Normally, most facilities only need one size or the other. So we're going to look at how to apply that before we continue.
The NASG is a lightweight compression suit made of neoprene and Velcro with 6 segments that close around the ankle, calf, thigh, pelvis, and abdomen. The Velcro fastenings keep the garment on tightly. The abdominal segment, number 5, contains a small foam ball to apply pressure to the uterus. Anyone can be trained to apply the NASG. First, place the NASG under the woman. The top of the NASG should be at the level of her lowest rib, and the row of yellow dots should be along her spine. Starting at the ankles, close segment number 1 tightly around each ankle. Make sure it is tight enough so that you can snap it and hear a sharp sound. Next, close segment number 2. Try to leave the woman's knee free so she can bend it. Apply segment number 3, the thigh segment, in the same way as 1 and 2. Apply segment number 4, the pelvic segment, all around the woman at the level of the pubic bone. Place segment number 5, with the pressure ball, directly over the umbilicus. Then close the NASG with segment number 6. Although 2 people can more rapidly close the leg segments, only 1 person should close the pelvic and abdominal segments, 4, 5, and 6, to avoid applying too much pressure. All segments should be applied using as much strength as possible. However, do not close the abdominal segment so tightly that it restricts the woman's breathing.
Are you breathing okay?
If the source of bleeding appears to be uterine atony, administer uterotonic drugs and massage the uterus. The NASG stretches, allowing room for your hand. The NASG adapts to many sizes of women. Here, for demonstration purposes, we are applying it to a fully clothed model who weighs 227 pounds, 103 kilograms. The NASG can also be used on a shorter woman. First, place the top of the NASG at the level of her lowest rib. Without closing the Velcro, check that the ball in the number 5 and 6 panel will be over the umbilicus. Now, move to the woman's feet. Check to see if the NASG extends beyond her feet. If so, then the NASG is too long. To shorten it, fold segment number 1 back inside segment number 2. Then start with segment number 2 at the ankles. Continue with the rest of the segments as on a taller woman. It takes 2 people to apply the NASG to an unconscious woman. Use the same principle as making an occupied bed. Turn the woman on her side. Fold the NASG in half along the dotted line. Fold the abdominal and pelvic segments, 4 and 6, so the Velcro is inside and won't stick. Place the top of the NASG at the level of her lowest rib and place the dotted line along her spine. Push the flat half of the abdominal and pelvic segments with the Velcro folded to the inside under her body. Next, roll the woman to her other side. Have the second person pull out the flat half of the abdominal and pelvic segments. Roll the woman on her back. Recheck the placement of the NASG by placing the ball, without closing segments 5 and 6, over her umbilicus. Then begin closing the NASG, starting at the ankles.
So I just want to show you because I think it's hard to see on the video, but this is panel 5. And so you can see how large the pressure ball is that is applied over the umbilicus. So it's quite big. And this is going to go ahead and apply it. You're going to make sure this is positioned over the umbilicus. So it's applying pressure to the uterus, slowing down because we expect that that is where the bleeding is concentrated. So this is going to continuously apply pressure in that region. So when would you apply the NASG? The NASG can be applied when a woman shows signs of hypovolemic shock from obstetric hemorrhage. It's appropriate for both internal and external bleeding. So if you are seeing signs of shock, but you do not see any external bleeding, you could still use the NASG if you are presuming that there is internal bleeding taking place. If the woman is already in shock, the NASG can be used to reverse that shock and to stabilize her. You can apply the NASG before inserting the IV because it will improve access to her veins if you're having trouble finding a vein. And you can apply the NASG late, which is, just before surgery or immediately after you've already completed the surgery, because it can aid in her recovery, shorten the time that it takes to discharge, and it protects her in cases where the bleeding was not successfully resolved by the intervention, because we have seen in some rare cases when the NASG was not used and she was left post-surgery after the intervention because there's less monitoring taking place typically once the woman has left surgery and it's presumed that she is no longer bleeding. And we have seen women have organ failure post-surgically because there was still some internal bleeding that was not detected and because the NASG was not in place. So it can be applied if there was a severe case that went through where she went through surgery. You can go ahead and put the NASG on her just to make sure that she is truly stable for that period while she is in recovery. The NASG does not avert the necessity for evaluation to identify the cause of shock. It does not avert the need for uterotonics if the patient has uterine atony. It does not replace fluid and blood replacement. You should still have her on an IV and she should still receive blood products if that is called for. She may still need therapy for coagulopathy, and she should still receive standard care for treatment of hypovolemic shock and for hemorrhage. Anyone can be trained to apply the NASG. Only one person is needed to apply the NASG. If the woman is conscious, you would be applying the leg segments 1, 1, 2, 2. So it would be one person applying the segments on the legs, and you want to do that simultaneously. So you want to get segments 1 completed because you're pushing the blood gradually up. So segment 1, segment 2 on both legs, segment 3 on both legs, and then the pelvic panel, and then the ball over her uterus, and closing panel 6. If you have two people, if she's unconscious, you can have two people apply it if they're there, just to do it more rapidly. If she's unconscious, you do need a second person to roll her carefully from side to side in order to get the NASG properly positioned under her. But again, anyone could be grabbed in that scenario. Ambulance drivers have been trained in some localities to apply the NASG, and they may carry the NASG on their ambulance if needed. And that can be a great way to make sure to facilitate the exchange of the NASG if it is moving between facilities, if the ambulance drivers are also incorporated. Some economic analysis has been done, and it has been found in Egypt to be cost beneficial. There were savings to the health centers of almost $10,000 per 1,000 women in shock. And the NASG was found in Zambia to be cost effective, saving $22 for each disability adjusted life year. In Tanzania, we conducted the study with Ifakara Health Institute across 280 health facilities. Data collected on 1,800 obstetric hemorrhage cases over a period of 15 months. And we found that the case fatality rate, the mortality due to obstetric hemorrhage, all causes of obstetric hemorrhage, it was 2.3% before the intervention, and it dropped to 0.7% after the introduction of the NASG at both the primary and tertiary care facilities. So that was a 68% reduction of mortality due to all-cause obstetric hemorrhage. The NASG has been widely introduced into health systems in countries including Nigeria, Ethiopia, Niger, and Colombia. The national deployment in Colombia happened very recently, I believe in 2023. The Colombian government has mandated that all facilities should have the NASG, which is known as the TAN in Spanish, along with the uterine balloon tamponade. And this is just a short video of the stockroom as they have supplied the NASG.
Hola, queremos contarles que ya tenemos disponibilidad de trajes antichoque para la prevención y el manejo de la hemorragia postparto Y también tenemos disponibilidad de nuestros balones de taponamiento uterino, el AVI con entrega inmediata. Hagan sus pedidos.
And also to point out that the uterine balloon tamponade has been shown to be very effective when used in combination with the NASG. They can be inserted in either order. The uterine balloon tamponade can be inserted first and then the NASG applied if she is not yet in shock. If the woman is in shock, you can apply the NASG first and then insert the uterine balloon tamponade afterwards, and it's considered a sandwich effect because it is applying pressure internally and externally. And because the uterine balloon tamponade does serve a different function than the NASG, it is used to treat uterine atony. So it is a complementary intervention. They are not duplicative in function. So bringing this back to where we started with the first response care bundle, the Lwala Community Alliance, along with UCSF, began testing the NASG and the first response care bundle in 2019. And these were some preliminary results just to demonstrate the importance of the bundle approach versus looking at the individual interventions. So you can see here that the most used intervention in the bundle were the IV fluids at 93%. Uterotonics were being used at 85%. The uterine massage was being done for 78% of women, and tranexamic acid was being used for 42% of women. That's understandable because it is the newest recommendation, and TXA was not available in all the implicated facilities in this study. But that yielded only 33, almost 34% of women were receiving the complete bundle. So even though IV fluids were being used at a high rate, uterotonics were being used at a high rate, only 34% of women were receiving all 4 of these interventions, or 3 interventions if TXA was contraindicated. So you can see that we're a ways to go in applying the complete bundle, and looking at it, measuring it as a bundle really helps us to see how big that gap really is in the use of these interventions, because when you look at them individually, it doesn't look that bad. So you can see, with the lowest use intervention, 42% TXA, even those 42% of women that were getting tranexamic acid were not consistently getting IV fluids, uterotonics, and uterine massage, or we would see that first response bundle at 42%. So there's really inconsistent use of the individual interventions, and we really need, putting them together as a bundle makes that clear how unequal the use of the interventions is. They were also using the NASG, and the NASG use was a bit lower than what we've seen in other cases. It was just under 50%, but we also know that we are seeing that the first response bundle does sometimes eliminate the need for the use of the NASG because the first response bundle can be very effective. And there's not really complete data on that because these are very new recommendations, but I think we will see that going forward. This is just an example of the job aid demonstrating how this approach was rolled out by the Lwala Community Alliance with support from UCSF. This is their reminder for using the first response bundle within 15 minutes, delivering the uterine massage, IV fluids, uterotonics, and tranexamic acid, with the reminder that TXA is only given if it's within 3 hours of birth. The refractory response bundle that Lwala was introducing across sites in Kenya was applying the NASG and then using the UBT and giving that second dose of TXA if the bleeding has not stopped after the use of the first response bundle, and then continuing to monitor vital signs, continuing IV fluids, and assessing the source of bleeding. So to close this segment, I would just like to share with you where you can access additional resources if you do want to learn more or are considering conducting a training for the NASG in your area, in your facility, or your region. There is the training video, the complete training video, which is available online, because we didn't cover things like how to perform surgery with the NASG in place, how to remove it. The NASG should only be removed in the presence of skilled providers who have access to resources to respond if the woman is still in need of further treatment. So the training video is accessible from safemotherhood.ucsf.edu. And the video is Saving Mothers' Lives, an NASG training video. And you can also access a toolkit of presentations and job aids, so complete presentations on application, removal, surgery, cleaning, They are available at safemotherhood.ucsf.edu/NASG toolkit. And there you'll find these resources, training and learning materials, materials for policymakers, material for researchers, materials for implementation, how to buy the NASG. So those are all available on the safemotherhood.ucsf.edu website. And please feel free to reach out to me if you have questions. We have conducted trainings in Mauritania, in Tanzania, in Kenya, Mali, Cote d'Ivoire, for the International Red Cross. So we have a lot of training experience. So if you have questions about training, please feel free to email me at mtherrien@icichildbirth.org. And now we're going to talk a bit more about implementation. Oh, and Karen's coming in right on time. Okay, so I'm going to go ahead and pass this over to Vicki. We do have some members of the Lwala Community Alliance team who are here with us. I know Meshack Wafula is here. Carren, I see, is coming in. So we will have time to ask them questions about the work in Kenya and the use of the bundle. Dr. Bengal is here in India, where he is also using, I believe, both the bundle approach and the, as well as the NASG. And I just wanted to share, because I was having trouble finding the research study, but it was the study, a cluster randomized control trial done in Zimbabwe, where UCSF, the team, did find that women who received the NASG earlier on, when they received that at the primary care level before referral, they spent a statistically significant shorter time at the referral hospital, and they had a non-significant faster recovery from shock. So that early application, in addition to reduced morbidity and mortality, has been shown in at least some studies. Vicki, do you want to go ahead and well, I'm sorry, I'm not doing a proper introduction. There's too much going on today. Vicki Penwell from Mercy in Action, where they have operated 3, I think actually technically opening the 4th clinic, midwifery clinic in the Philippines, as well as having done a lot of emergency response around the region, and having their School of Midwifery in the US, has extensive experience with the NASG, and I believe also using the parts of the bundle that you're able to now in the Philippines, is going to go ahead and share some of her experience, and the experience of the midwives. So Vicki, please go ahead.
Okay, thanks, Michelle. Yes, I was actually looking it up today in preparation for this. We bought our first NASG in 2011, so it's been a while now that we have been using them in all of our birth centers. Michelle wanted me to mention also that for 5 years, we ran a birth center in the United States and used the NASG there also. So we use it in all settings. We also have several people on the webinar tonight with me from Mercy in Action College of Midwifery, and it is also taught in our college, and a lot of our graduates will purchase them for use in the United States as well as in other countries. Real quickly, our experience has really lined up with what Michelle was saying, in that when they first came out, they were meant to be something that we used to stabilize a patient while we got them to a higher referral level if a baby was born out of hospital. What we found in our midwife-led birth centers is that if we put them on sooner than later in a hemorrhage situation, that we were having very high rates of women never needing to transfer to a hospital, never needing a blood transfusion. So that was really significant results, and we continue to see that. As long as we really keep up the training everywhere we go and make sure people remember it and don't wait to put it on, like don't wait until she's really bad. A lot of times, I mean, and that's huge in our setting, to avoid a hospital stay, a blood transfusion, the expense, but also the separation of the mother and baby. And that was something else Michelle asked me to share with you. I'm going to share my slides, because we were saying that a lot of the pictures that we have of the NASG doesn't show the baby breastfeeding. So are you able to see that slide okay now, Michelle?
Yes. Yeah, we can.
So this picture, if you notice, these are canvas walls. This is actually in a disaster tent in 2013 here in the Philippines, when Mercy in Action responded to the huge disaster down on Leyte Island. And we're delivering hundreds of babies in tents for several months then. And we used the NASG there, but every mother that, that is in our facility is breastfeeding along with, the IVs and the massage and the bundle. And we found that people's concern is sometimes you can't massage the uterus well with NASG on, but you absolutely can. You can assess bleeding. And so we have been doing the whole bundle plus the NASG minus in our facilities. The TXA is not yet available for midwives to administer out of hospital, but we do have it in the country. And then here's another picture again of a mother with her IV running, but nursing her baby. So I just wanted to really show these pictures because we don't get to see many like that. And we have to remember that we don't separate the mother and baby just because there's a hemorrhage. And the wonderful thing about the NASG is it allows us to keep somebody in our center and they don't. I wish I had arrived here tonight ready to tell you the exact statistics, but it runs somewhere between 50 to 70% of people that we can keep, that they actually, their vitals stabilize, that they are able to recover without ever having to leave our birth center and don't need a blood transfusion and recover well. We have also had those experiences also where we've had to get someone a blood transfusion and it took an inordinate amount of time and people have stayed stable in the NASG for 17 hours one time, over 20 hours another time, just because the delay in getting blood can be so long. So they really are very miraculous in that case. Also, another thing we did in the disaster zone was we had shipments ordered in and we donated like dozens of them to the local, any midwife who had a facility that was still standing and was delivering babies, we were donating them. This is a picture of us doing a training with Doctors Without Borders staff because they didn't have one in the disaster. So we really believe in these so much everywhere and all the way from, the extreme of being in a disaster zone where all the hospitals are smashed and you really, really just have to take care of things, to being in a center in the United States where we were 8 minutes from a hospital. We still wanted one on site there.
Vicki, I think we're still on your first photo. I think it's not switching through for you.
Okay, what do I need to do?
If you're sharing it again. Oh, there we go.
Okay, now you can see them. Okay. So there's okay, thanks for letting me know it was stuck. Yeah, I have several breastfeeding pictures and women with their babies, but this is us then donating them to the midwives and to Doctors Without Borders. And then Narissa is also on this call with me and several of the midwives here in the Philippines. And when we rebuilt birth centers after the disaster, that was one of the early donations was the NASG, and now all of our centers use them because they're just invaluable. So we're a big proponent. We actually wrote a training course that we provide for free for people as a continuing education. Like I said, we teach it to the 150 or more students in our college, and we're just really getting the word out. To me, it's a really important part of the bundle. So anyway, thanks, Michelle. That's trying to keep it under 10 minutes, but let me know if there's any other questions or anything I missed highlighting that we had talked about.
Sure, Vicki. I just want to go ahead. I don't know if anyone wants to put the questions and comments in the chat for anyone, but I do want to ask, Meshack has been here, I think, the whole time. I think is still with us, yes. Meshack, do you want to add anything about your experience, any comments? And I know I see Carren as well.
Yeah, thank you, Michelle, and thank you, Tim. I'm glad to be part and parcel of this meeting. Yeah, my name is Meshack Wafula. I work for Lwala Community Alliance, which is based in Kenya. I want to say that since we started implementing obstetric hemorrhage by bundle approach with the NASG, I can say that we've really averted many maternal mortalities. Most of our facilities we have healthcare workers who are trained and are capable of managing these obstetric hemorrhage cases, early detection, and also we have what we call facility preparedness, where all the bundle machineries are at place, so that in case of any emergency, then all healthcare workers are ready to manage an obstetric hemorrhage cases. I want to say that we also did a study, as Michelle explained, and we really reduced a case fatality rate among obstetric hemorrhage cases, and we really averted a lot of maternal mortalities. We've done that. Now we're expanding to other counties within Kenya, just to replicate what we did in southern part of Nyanza, that is in Kenya, and we're expanding to more counties so that we still implement to avert maternal mortalities due to preventable obstetric hemorrhage cases. Yeah, here with me, I've seen our colleague who is also a champion, Carren Siele. I think she can maybe contribute or have something to the team. Carren, if you can hear me, kindly go ahead. Thank you, Michelle and the team.
Thank you, Meshack. And I have, oh, sorry, go ahead, Carren.
Yeah, thank you so much, team. And I want to appreciate this meeting. This is my first time training, and I'm representing Kenya. We work together with Meshack, Malaysia, and clinical training. And part of this clinical training is basically to work with the counties on the Ministry of Health to scale up training on the PPH bundle. So we started this program in Kenya in 2019. Initially, we used to do one training that is called the NASG, but we started scaling up the program. And as I share my screen, I don't know if you can all see my screen. One of the beautiful pictures that bring memories when we look how many women are being saved with the bundle approach. So the first picture here is Lwala Health Facility. It's a small health facility in Western Kenya. So this was an hemorrhage case that happened, and you see the healthcare providers, trying to provide care to ensure, the woman is on NASG, there's blood transfusion, and of course the UBT because it was atonic uterus. So we've seen a lot of women surviving or averting maternal mortalities with the use of bundle approach, and also the number of referral across the counties that we are working with actually reduced because, women are able to, they can be able to conserve the little blood they have. They can be able, to transfuse and manage, and women are surviving. So one of the approach that we use is what we call mentorship cascade. So training the healthcare providers, and then we scale up mentorship approach to ensure, we are reaching many people as much as we can using the little resources. So we train the champions that's who are used in the, to roll out the training. And it has really, really improved the maternal outcome. And looking in terms of adoption by the Ministry of Health, this is a picture, one of the facilities for the Ministry of Health. They have really adopted, and when we look in one of the county, Migori, it's no longer, PPH is no longer a problem because we've trained healthcare workers. Healthcare workers are very competent in terms of managing mothers who experience obstetric hemorrhage. And then to share my second photo, this is a healthcare worker, a champion in one of the counties, Kilifi County, working in a very big, health facility, referral health facilities, supporting women and ensuring, we are averting maternal mortality. So PPH is still the main killer of maternal mortality in Kenya. But the organization that I work with is looking forward to scale this to ensure we are reaching counties with high maternal mortalities between now, 15 counties between now and 2018. So that's what I wanted to share from this side. But just to appreciate that PPH bundle works, it has really saved a lot of women. And, coming from a country that has low resources, then, coming in a country where health system is still weak when you talk about, number of healthcare providers, when you talk about the infrastructure, when you talk about, resource allocation, it's still very, very minimal. And most of the time, health is neglected or few resources are allocated. So when we have, bundle approach, then we use the less resources to scale up the implementation and to support women to avert maternal mortality. So these are training or an innovation that we take. It's really falls in our heart because we've seen a lot of impact when it comes to reduction of maternal mortality. So thank you so much, Michelle, and back to you.
Thank you, Carren. Thank you, Carren and Meshack. I wanted to ask.
And again, Michelle, I forgot to say that, and to appreciate you, because when we started this program in 2018, we didn't see ourselves even scaling beyond, the smaller facility in the rural setting. So you trained us, and then we say, let's put a test on this innovation. So when we tested the innovation, it was really, really working. And now the Ministry of Health were like, what are you doing differently? And that we can be able to copy in our health facilities to support the outcome. And you say, hey, this is our magic garment. And then it was like, can we scale it up? Can we work in a small facilities? So we started with small facilities. And then out of one facility, then, Migori County is able to, to deploy all this innovation to all the healthcare facilities. So all the 214 healthcare facilities have this innovation to support the women. And PPH is no longer a problem in this county. Eclampsia is now taking lead. And that means PPH bundle is working to save the women in rural facilities and of course in, basically where resources are very, very minimal. Thank you, Michelle, and back to you.
Thank you so much, Carren. And I have a question. Do you know approximately how many facilities or Meshack you're at in total in Kenya right now?
Yeah, at the moment we are implementing to around 385 facilities. That is Migori, Kilifi, Baringo, and Homa Bay.
Okay.
And all those facilities are equipped with pneumatic and show garments. And they're really actively bundling. Thank you.
Yeah, 385. Yeah, it's incredible. And Carren, thank you for reminding me, because I remember when we talked back in 2018, the plan was for 14, and now you're at 385. So that is a lot more than we expected. I don't know if people would like to put comments or questions in the chat or about the bundle, about the care bundle, about the NASG, about using them with other devices such as the uterine balloon tamponade. I know, Mary, I can see you here, and Poonam and Dr. Bangal. Actually, I want to call on Dr. Bangal and Dr. Poonam to give your comments when you just raise your hand if you're ready, or anyone you can raise your hand and unmute right now. But I want to thank everyone for being here. And I think we saw that we have a large number of people who do have, like, when we did the poll, we had 57% who do have access to the NASG. So we have a good contingent who does have the NASG, along with some who do not. So would anyone like to comment or ask a question?
Michelle, I would like to say something about NASG because when we started this PPH EMC bundle care and Dr. Thomas Buck was with us, so we went on to the district. So we took up the whole district and 24 PHCs, 9 CHCs, 1 district hospital and medical college. We vertically integrated. And then we distributed these NASG to some of the facilities, CHCs, where from we were seeing that a lot of patients are being referred. And we have a good record of, women who were sent with NASG and those who were referred without NASG, and what was their survival, what were their morbidities. So we have a very good data about it. And certainly NASG has helped significantly. So now government has even provided it in the PHCs where from the cases are being referred. So now the women are coming with NASG. And as we do not have too many doctors in primary health centers, so we had trained the ANMs and ASHAs also in inserting the UBT when the women is bleeding and putting the NASG and then sending them. So we also compared NASG alone and UBT and NASG together. So we compared, and the data clearly states that the women with NASG UBT were the best survivors. Then was NASG, and the last was the one who were referred without NASG. So things were very different here, and here also we could reduce our PPH deaths to 0 for nearly 1 year and 8 months before COVID came. And now also past 9 months, we have no deaths because we have done the second round of follow-up in these facilities.
Thank you so much, Poonam. Anyone else? Dr. Bangal? And so Lenka is asking where it's purchased. So there are a few distributors. And actually, now that I think about it, I need to check and see what are the distributors in Europe. But there is Blue Fusion, which is the group that has partnered with UCSF with a lot of our distribution. So Blue Fusion is available. They also work with Via Global Health. We do have the links, I think, on the UCSF website on where to buy. Maternova sells it as well. I know that there is a local manufacturer in India. They do have slightly different, oh, I'm going to try to unmute you, Dr. Bengal, sorry. There are some newer manufacturers, so not all of them have gone through the same testing. It's the Blue Fusion version that we tested for up to 140 uses when you clean it properly. The cost can range based on where you are and who you're purchasing from and what quantity you're buying. It can be as low as $42. I think I saw it around 70, 74, something like that from Via Global Health. And Vicki, you said how much Zoex is the distributor in the US, and I've already forgotten the price.
Yes, they sell them for, it's right around $260, which is quite a bit more than you can get it in other countries, but they're still worth it the day you need it. And we have also used ours. Yeah, we've not gotten to a point where we can't reuse them over and over if you just keep washing them properly.
Yeah.
Okay.
Yeah. May I speak something?
Yes, please go ahead.
Yeah. So I'm Dr. Bangal. I'm heading the Department of Obstetrics and Gynecology in a busy maternity hospital with almost 10,000 deliveries per year. These obstetric emergencies, including hemorrhage related emergencies, are almost daily affair. We, as Dr. Poonam said, we started implementing this PPH bundle care since last 6-7 years, and maybe my center has gone out of this hospital and trained more than 2,000 healthcare workers in this application of the NASG. At my place in the hospital, knowing the possibility of getting patients from different areas, I have put the NASG at emergency unit, in the operation theater, in the labor room, in the surgical ICU, medical ICU, so that people don't have to run around to get the NASG. That is one thing I want to say. Poonam also said that we went to public health facilities and provided training to them, and we are finding that it is getting the results. In addition, what I did that in the area from where those private gynecologists doing private practice, I have 40 gynecologists in this area. They were asked to purchase, means I actually initiated and mediated that purchase. And now those gynecologists are using these NASGs and sending the cases timely, and that's how the morbidity and mortality has come down. We were fortunate to work with Dr. Burke, Stulan Miller. We conducted some workshops in India, and also Poonam and myself got opportunity to go to Colombia to at Dr. Maria Fernandez's critical care unit. And with these training inputs, we are in position to train others, and we are doing our best in India to increase the use of NASG in healthcare facilities.
Thank you, Dr. Bengal.
Yeah.
It's really fantastic. I'm just going to go ahead and share so that people can see. So if you go to the UCSF, so the safemotherhood.ucsf.edu NASG toolkit. I hope I put that right. I might not have put that right into the chat. I'm sorry. It's NASG toolkit. There is a link on how to buy, and I think we need to update it because I think not all of the distributors are there, but Blue Fusion's link is there. Mater Nova is there. We need to add Via Global Health. Zoex is there. And we'll update that. And I do need to check for Latin America. What are the contacts in Europe? I know that Via Global Health distributes they have a base in South Africa, and then Visco in India. Yeah, Sarah, we're gonna have to talk because I know there's others that are trying to get it, and I'm sure we've got to figure out something better for South America.
Yeah, I found that the distributors were happy to ship them, but then they got hung up for almost a year. And
I mean, I do think customs is challenging everywhere. And so that is something for anyone who is planning a training, make sure that you've gotten them through customs before you schedule that training. We've had that scenario. We've had the scenario where people have been trained and then it's taken a year to get the NASG, and by the time they get it, everyone's forgotten how to use it. And that is something that you do need because it is something that is hands-on. I mean, also with the bundle, all of these skills need practice, but for the NASG, especially for smaller maternity centers where you're not seeing a lot of PPH, you do need to do drills periodically to get the hang of how to apply, because it can be very awkward. I'm just gonna grab mine. It's big, and if you haven't messed around with it, when you unfold it, the Velcro will stick to itself. And we do see that there's a bit of a learning curve with getting used to unfolding, folding, and you can feel very confident, but if it's an emergency, you don't want to find that you've forgotten how to apply it. Oh. Maria Teresa, is your question about other PPH interventions? And you can unmute as well. So you would do all your other interventions. So the NASG does not change any of your other interventions. You still want to do all your other management steps. You do always want to use uterotonics. And with the way the first response bundle has rolled out, the recommendation is to give all of the bundle components at the first sign of postpartum hemorrhage. You want to be starting an IV line. You want to be giving IV fluids. You want to be giving uterotonic. You want to give tranexamic acid as soon as possible after the hemorrhage begins, if you're within that 3-hour window after she's given birth, because the TXA in particular has a diminished effect as it gets farther from the delivery time. And once you hit 3 hours, it can actually be harmful if she's gone past 3 hours. So you need to get that first dose of TXA within the first 3 hours, as early as possible, uterotonic as early as possible, IV fluids as early as possible, and you may actually, and uterine massage, and you may actually avoid the need to use the NASG. You could actually resolve the bleeding at that point. If you haven't resolved the bleeding, you can use a uterine balloon tamponade, you can use the NASG, and then move on with your management, additional doses of tranexamic acid. So you don't take away anything. You can perform surgery with the NASG on, you can perform vaginal procedures with everything in place. If you are doing surgery, you're just opening up the abdominal panels. So you're just opening up panels 4, 5, and 6. So just exposing the area that you need in order to perform surgery, keeping the leg segments in place so that you are still pushing the blood so it's not pooling down in her legs. Exactly, as Poonam is saying, it is a mechanical method. It only works when it's in place. It's completely safe to use it during surgery. It takes a lot of training to reassure everyone to get used to how it works, because when you open those abdominal panels, her blood pressure will drop. You may have to the anesthesiologist may need to give additional boluses because there is going to be a large change in blood pressure when you open the abdominal panels. Surgeons sometimes are not used to operating with the NASG on. So that can be a bit of a learning curve to reassure everyone that this, can safely be left on during surgery and should be closed as soon as the surgery is completed. And it's going to keep her stable, and it's going to bring down her recovery time and also keep her safe if you haven't really resolved that bleeding. We often see it early on when the NASG is rolled out to a new facility, is that she'll go into surgery, people will feel very confident, they'll take the NASG off, and they'll have sometimes very poor outcomes because of that. And, we will see maternal mortalities that happen when they had the NASG on the patient at a point and it got taken off too soon. So we didn't get into removal today, but you want to leave it on until she has been stable for at least 2 hours. So you're going to leave it on once you've done definitive treatments, once she's had her blood transfusion, and you're going to wait a couple hours to make sure that her vital signs have been stable for 2 hours before you start removal. And there's no harm to leaving it on. There have not been any incidences of it being left on too long. It's not a tourniquet. You're not cutting off circulation in the lower limbs. Jen, it's good to see you here in the comments as well. You can feel free to unmute if you want to add anything. We've got time. And actually, I did want to ask a couple more questions. I've put into, now there's been a lot of activity in the chat, but if you scroll up in the chat, for those who missed the last webinar, which was the qualitative study on interviews with women from La Florida Hospital in Chile, that is now on YouTube. The link to the YouTube video is up in the chat if you scroll up a little bit. It's also, you can just look for the International Childbirth Initiative YouTube page and you can see the videos. And this video will also be posted to YouTube when it's done. I did want to ask people about what they are using if you are doing quantitative measurement of blood loss, because that is the other current recommendation that was added. Oh, I can't get to my questions anymore. Oh, here we go. So we did have 57% who have used the NASG. We did want to see what everyone is using to measure blood loss, because there are new technologies coming out. People are working on new lower cost calibrated drapes for measurement. The issue around the drapes is environmental friendliness and working on a biodegradable drape, because we don't want to be creating a lot of waste if a drape is being used for every woman, and also bringing that cost down, because if it's every single woman is getting a drape, that can get very costly very quickly.
I just will say something while everybody's doing this poll.
Yeah.
The only problem, one of the problems I have with the drape is the assumption that people will be laying on their back on a delivery table. We have a lot more upright births. I think in our center, we do a lot of birth stool births or squatting births. And so it's extremely easy to catch blood if you have an upright birth, because it's all going to go into you can put a bedpan or a calibrated, ball that already has measurements on the side. So it's just to keep in mind that, you know, it's another advantage of upright birth is being able to get pretty accurate blood measurement.
That's a really great and very important point. Vicki, I can always count on you to bring us back to the 12 steps in all scenarios. You've been doing this for such a long time. Yeah, having women upright is really important. So I'm just seeing that the feedback we got from Kimchi was a blood bag. Carren was saying a measuring jug. Sophie is using a measurement drape. Dr. Bengal is using the V drape and measuring dry pads and soaked pads, and Jenny also put weighing pads as what's currently being used to measure blood loss. So I think, oh, Ronnie, you're here. Yeah, I haven't seen the NASG used in Chile. Ronnie, have you or has anyone in Latin America been using something like a bundle approach, like a bundled postpartum hemorrhage care? Or is that new? Because I know that in Colombia, okay, we'll come back. So here, I'll just reply to you. So I know that in Colombia, they've been using the uterine balloon tamponade and the NASG together for some time. And in Chile, also using bags for measurement. Thank you, Deborah. So I think that we're going to be on time, actually. This is amazing. So Deborah has to go. Ray, I don't know if you want to add any last comments. And I do want to ask a question. I'm going to launch one last poll as people are on their way out. If you can, everyone can stick around for a minute. But I wanted to invite Ray, who is our representative from IMBCO, along with Deborah, sponsoring these webinars, to if she'd like to add anything. If you're still here, Ray, I think so.
Yes, I'm still here. Thank you again, Michelle. As a non-clinician, I really found this very informative, and I've obviously known about it. I think, you know, Vicki was the first one to bring this to our attention. So I'm happy to see this happening in the United States. I sure wish that the intention to serve other countries when like churches do donations and everything, to not send formula, but send the bundles, or, you know, send the NASG. So I'm really going to have my heads up instead of saying, don't take formula with you. I'm going to tell them about this. And so I appreciate the links.
That's an amazing idea, Ray, because I think that's the big question of like, how do we get the NASGs out places? And it can be very tricky. And a lot of times the governments are interested to bring the NASG in, but then, you know, they don't want to do because it is an initial investment. It has kind of a larger startup cost. And then once it's there, it's easier to maintain it. And then there's the training aspect of it. But I think that's a great idea. That would be, we haven't tried that strategy.
I think, Ray, we need to organize a campaign.
Yes, let's
get together on that.
Yeah, okay, Sarah, we'll do it.
I had a funny experience at a clinic where we brought the Helping Mothers Survive training to the clinic from Laerdal. We showed them the NSG and we're like, have you all ever heard of this? And they were all like, nope, never seen that, don't know what that is. And one of the nurses was like, wait guys. And she runs off into one of their storage closets and pulls one out. And she's like, is that what this is? And they had no idea it was there. They didn't know what it was for. And so we are running into cases where they're around, but nobody has been trained. And so there's sort of two sides to that coin of making sure that people that have them are able to use them, and then making sure that people who don't have them get them.
It's true, Sarah. I mean, like, that's something that I think we've also really seen, is that there can be a big underestimation of how much training and initial training support is needed. And I think that's the amazing thing that Dr. Bengal and Dr. Poonam have done with, you know, all the training in India, and then Carren and Meshack and the team at Lwala Community Alliance with a lot of cascade training and reinforcement and mentorship to make sure that people aren't just leaving them in the cabinet, because it's very, very easy. It happens much too often. And it's really kind of heartbreaking when that happens. Absolutely. And I was going to say, Ray, the thing is, as a doula, it's really good to know about the NASG, because it is something that, like, feasibly a doula can apply it if, if you are supporting a woman and there is an emergency. So that's something that, doulas should absolutely be trained in how to apply an NASG if there is an emergency during a home birth for transport. And I was speaking with someone in Utah talking about how it would be really good to have them on the ambulances, because it's a really rural environment and there's long several-hour drives in Utah. So I think it's really been a missed opportunity in the US to get this into some of the more rural parts of the country where it would be really impactful.
Yeah, that's a good point, Michelle. And I'm definitely going to add it to my doula training, just so it's in the back of their head, at least, that there is a way. And I know our next ICI webinar is going to be about a doula program in a facility. So let's hope we hear from them about that it's on board there as well.
Yeah. Yeah. And Mary, that's really interesting to hear that. Oh, and we should also plug the next the next webinar. So the next webinar will be in 2 weeks. We will be going over what are the components of a doula curriculum, what are the components, what are the requirements to certify doulas in different countries, and how doula trainings are being adapted in different contexts in Africa, in India. We're going to have a wonderful presenter from the Fernandez Foundation with their brand new doula training in India. And I just wanted to, I don't know, Mary, if you're still here, what are the cases when you apply the NASG if someone is already in shock when she arrives to your health center? Mary is working at a health center in Western Kenya with the Lwala team. Mary, I don't know if you can unmute or if you want to put it in the comments. I know that I think you do sometimes get women who have already been hemorrhaging before they get to your health center.
Maybe I can speak. I
Sure.
think Mary is not responding, but just to share experiences here in Kenya. Because of the delays, especially the second delays, sometimes women come to the hospital after maybe home delivery or complicated abortions. Then they come when they are really, really in shock. So what we do first, or what we've trained the healthcare workers, is when a woman comes in with, bleeding, before even assessments, then you apply NASG, so that even as you continue to support this woman doing other, first response bundle, then this woman continue to survive. I want to share a typical example. During the introduction of NSG, so we had a woman who came in really, really in bad state. So she had bled at home because of, complicated abortion. So when we came to the hospital, even the caregivers were saying she's already dead. So we received the patient and we transfer immediately to the emergency unit. And then, of course, because she was bleeding, and the caregivers told us that I think the lady was pregnant. Then what we did first, we were trying to look for the veins, but they were not visible. So what we did, we applied NASG first. And then, after application of NASG immediately, then we were able to visualize the veins. We were able to insert IV lines. And these stories are, around our countries. Our country, Kenya, where sometimes women come late, already in shock or severe bleeding, then we don't follow the first response approach, but we apply NASG and then we start the other processes of management. Thank you.
Thank you, Carren.
Don't speak in of them.
Oh, Mary, hi.
Hello. Hi. I wish to share something on NASG.
Yes, please.
Yes, we have some unique cases. No sooner a client gives birth, you remove the placenta, then she bleeds, she pours a lot of blood. The first thing, you just apply NASG to make you comfortable. You shout for help. Within 3 to 5 minutes, you get your team. Then you start the first response bundle. It has really saved a lot. It has reduced the necessity of referrals. and we have good outcomes.
Thank you, Mary. Yes, so Lenka's question. So there are research studies. So the let me look. So the best one, so a lot of the research studies are on the Safe Motherhood website. There was a RCT, and there has been probably the most definitive. There is a combined analysis. Let me see here. So there was the combined analysis study that was done by Pelleggi Castro. Let me find it. That put together several of the other studies. And there has been research that's been published more recently. So we do have the Tanzania study that was published, that was an observational study. Let me find this though for you. So this study that was done back in 2015. So there are some studies that have come out more recently, but there was a systematic review that was done independently with a few people from WHO putting together the existing studies on the NASG and their findings. So there was only one, the cluster randomized control trial that they did include, and the observational studies, and they did find that the NASG was better than standard care for maternal mortality reduction. And they also found a non-significant reduction of maternal mortality risk from the cluster randomized control trial. They didn't find a difference on the use of blood products, although that has been found in a non-statistically significant amount in other places. So this was part of the basis for, this has been part of the basis for the evaluation for WHO's ongoing recommendation of the NASG. And you can, I can send you a couple of the studies if you need that for advocacy. And they are also linked, I hope. If you go to the toolkit, if you go to the publications, so a lot of the publications on the NASG are here on the Safe Motherhood website. Some of the recent evidence. And then if you go to the toolkit, you will also get the, so if you go to the toolkit, you will get the training resources. And so this should give you actually all of the presentations. This gives you all of the PowerPoints on all the different aspects about using the NASG, an introduction, application, how to do referral and transport. There are, and these are also by what level you're at. So if you are at a primary care level, if you're at a higher level facility, there are modified presentations for each of those, as well as job aids that give you a very quick overview on how to use the NSG. So those job aids are there as well. And we also have some translations if you need them.
Yeah, I've translated some of those into Spanish, Michelle. I can send you what I have.
I'm curious because I feel like multiple people have done translations and we don't have a definitive one up on the website, so we have to figure this out.
Okay, I'll help.
Yeah, because I know Maria Fernanda has it because they are just an emergency obstetric unit. I think they have 28 emergency obstetric beds, and they've been using the NASG for many years. A lot of the Spanish studies are from her. It should, Holly, the link should be there. And if it's not there, I will fix it. It's supposed to be there. So I think the 2015 study should be on the website. Sometimes I have trouble finding everything. Okay. We do have the materials. Yes, we do have all the materials in French. We have all the presentations in French. We have the job aids in French. I taught it in Mauritania, and I think that's when we did the translation, and we updated it for Muso Health in Mali and Cote d'Ivoire. So the last time I taught it in French, I think was last year or the year before, 2022. So we have updated presentations from 2022 in French on the NASG, also including the TXA recommendations. So yes, if you need those, Rose, please email me, or I can also reach out to you if you need those resources. We've even done them in Creole for Haiti. The presentations were translated into Creole at a point. So email me. I'm putting my email in the chat. I will send you both the French and the Creole. You can use either one. M Therrien, MTHERRIEN at icichildbirth.org. If I could come to Haiti and teach it for you in Creole, I would. Okay, so thank you, everyone. I appreciate all of your questions and involvement. We put up a poll because I did want to hear if you can let us know what was helpful during today's session, because we haven't done a lot of these types of sessions on some of the clinical recommendations. So it would be really helpful to hear your feedback about what was most useful. If you haven't answered that question, if you could take a second to do that before we close out. I want to thank everyone for your participation today. It was great to see you. We will have the recording up promptly, I hope, on the YouTube channel if you missed any part of it and you would like to go back. Thank you so much to everyone who came in with your experience. Vicki, thank you so much.
Welcome.
Carren and Mary and Meshack and Dr. Bengal and Dr. Poonam. It's so good to see you. It's really great that we have so many advocates.
Yeah, thank you, Michelle and the team.
Yeah.
Thank you, Michelle.
Good to see you. Thank
Yeah.
you. Thank you, Tim. Thank you, Michelle. See you.
Thank you, Carren. It's so good to see you.
Good to see you. Bye.